It's basically in front of sculpture is in front of Amrita Institute of Medical Sciences in Cochin. So I got this photograph. So as far as the young knights, I would call those postgraduates in pediatric cardiology are concerned, there are three things again to know. One is to understand the physiology of cardiac problems. Second is the face the questions in the examination. And ultimately, it's all about, of course, passing the exam. Then only we can serve people with the regular this thing. So my topic given to me by Manish is a child with heart disease, the art of examination. So I was wondering what is the way forward with this particular very intriguing title. So what I thought was I will show you some glimpses of clinical Vinay so that we will go forward in this particular thing. And as a disclaimer, I would say that I'm always reminded about Oscar Wilde's statement that everybody who is incapable of learning have taken to teaching. So, that is my disclaimer. And the prologue is that basically, I think there is an art in cardiovascular examination. And there is a quotation called a clinical gaze has much common with an artistic eye. On your left-hand side, you are watching William Harvey explaining his circulation to his colleagues. On your right-hand side bottom, you are seeing the great Van Gogh painting his paint. And of course, there is another situation. It's a very famous painting. Many of you must have seen this, where art meets medicine. It's a care of sick. A very great painting. And of course, ultimately, the greatest artist and the scientist in relation to cardiovascular science, apart from William Harvey, would be Da Vinci, because he was the first person to draw a diagrams of heart disease, and also the first ever diagram of a congenital heart disease was drawn by Leonardo da Vinci. So I think we must remember him. I'll go on to some frames. One is that 14 days old baby girl has a bilateral pedal edema with respiratory distress and possibly an acute heart failure. The echo reveals significant coarctation with the LV dysfunction. So naturally, one is tempted to feel that this pedal edema may be due to part of heart failure, but we must remember that infants and newborns, the edema in heart failure is a very late phenomenon. So a question is, what could be the reason for the pedal edema? Basically, we should think whenever you have a so-called baby girl having coarctation, we must definitely think of a Turner syndrome. So the edema may be basically because of the Turner syndrome. So that is one practical point you have to know when you examine a newborn baby. So now we are going to an adolescent, a 17-year-old girl who has no cyanosis of the upper limb. Saturation is absolutely normal, whereas the cyanosis of the lower limb is only 81%. And you can understand that there is a genuine differential cyanosis in a 17-year-old girl. So, of course, we must think of an Eisenmenger PDA because there is a differential saturation in the late teens. So that brings us to a very important sign and symptom, that is central cyanosis, which was probably discussed or described 5,000 years ago in Egyptian papyrus. And we all know that the normal saturation is above 95 or 95 or above. Desaturation is less than 95. And we all know from MBBS days that the clinical cyanosis is evident when saturation drops down to around 80 to 85. And the definition also we know. And if you go through Braunwald, you will find instead of 5 gram, which we have learned during our postgraduate days, it is around 4 gram per deciliter to produce a central cyanosis. And in an adult, at least, there is some correlation between the content of reduced hemoglobin and arterial saturation, so that 85% is roughly corresponds to 4 gram of reduced hemoglobin. That is probably the reason why they put 4 gram instead of 5 in the definition. And we also know that there can be central cyanosis versus peripheral cyanosis. And pediatric care, whenever we have a pediatric care, we should know there is something like an acrocyanosis, which could be present transiently for at least 8 to 12 hours. But beyond that, that definitely would be an abnormal situation. And again, during our third year MBBS days, school days, we have learned how to differentiate between the central and peripheral cyanosis in terms of appearance, the distribution, the warmth, the mucous membrane, and applying the warmth. And then, of course, naturally look at the arterial saturation by pulse oximetry. And the cyanosis could be uniform or differential. The usual differential cyanosis, which we have already seen, a reverse differential diagnosis, which is again a very rare event. So if you have an upper lobe is pink and the lower lobe is blue, the MBBS teaching PDA Eisenmenger, but as a subspecialty student, we should know PPHN is a very important cause in the newborn. We also find sometimes a critical coarctation in the newborn producing a differential saturation. And the classical upper limb blue and the lower limb pink, the all relative is a DTGA with a severe pulmonary hypertension with the ductus, so that the ductus feeds the upper limb from the. And this is another practical question which could be asked in the examination. What is meant by differential saturation? Around 5% difference between upper and lower limb. Some people say 3%, but it is around 3 to 5%. But to get a differential cyanosis, you need to have a 10% difference, and it's very difficult sometimes to get a clinical appearance of a differential cyanosis. And very importantly, that means that even if you have a desaturation, the child may not be cyanotic. So cyanotic heart disease can exist without clinical evidence of cyanosis. Another frame is a 17 days old baby with congenital heart disease with deep cyanosis with significant desaturation. But there is, however, no clubbing. Very deep cyanosis, but there is no clubbing. So the question is, are you surprised? So you can actually formulate your answers on mentally and look at the possible answers. So we are not surprised at all, because we know in congenital cyanotic heart disease, it takes around 3 to 6 months to develop a clubbing in this particular condition. This is another exam question. We'll ask you, at least you need around 3 months. And usually in the respiratory only, we get a very fast development of clubbing. Now, I always found that MBBS, MD, and subspecialty students, at least half of them have some difficulty in grading the clubbing. They have some confusion. So we have to have no confusion here. The first degree is increased fluctuation of fingertips. The second degree is obliteration of the nail bed angle. Third is the increased AP diameter of the fingertips. And lastly, the drumstick or parrot beak appearance. So you'll be very clear about this, because this particular definition has been had a reference in Braunwald. It is in a JAMA article in 2002. So we must be very clear that this is the grading of clubbing when you face the examiner. And we also know there are some signs, Shamroth sign, recent sign, see, 1976, which shows that the angle between the two fingers, there is that the triangle is obliterated. It's very visible here. And there is another phalangeal depth ratio, proximal and distal. It will be more or less same in severe clubbing. And we also should, they could ask you causes of clubbing other than cardiovascular system. Of course, the most common ones are from the lung. It also can come from GIT, and hyperthyroidism can produce a clubbing, which we call as a thyroid acropathy. So I think, again, a favorite question of internal medicine examiners, but sometimes could be asked in the subspecialty examination also. Now, this is an abnormal looking child of 6 months with heart failure and a developmental delay. And you can see the palm, the foot, the echo on your right hand side, and a chromosomal karyotyping. And I suppose that everybody knows what is the diagnosis. This is, of course, a trisomy with atrioventricular septal defect. And again, you should be very clear, prevalence is 1 in 700 live births. and nearly half of them will have a congenital heart disease. And these heart diseases are usually atrioventricular septal defect followed by inlet VSD. And most common, another question asked is, what is the most common cyanotic heart disease in trisomy? It is a tetralogy of Fallot. Now, this is another abnormal looking baby of 3 months with heart failure with a huge VSD. Baby has also hypertonia. People are suspecting a chromosomal anomaly. That is why they have done a karyotyping. So this is perhaps the only chromosomal anomaly with hypertonia. So that's a very interesting thing. And you have the overriding of fingers will tell you it's most likely a Edward syndrome. So the unfortunate thing is that 95% of them will have a heart disease, but practically everybody dies by 1 year, mostly because of non-cardiovascular issues. Now, this person or patient can come to you in the examination also. You have a adolescent with a particular ECG and the lady is on your right side. So you can guess that a whipping of neck in a boy with a right upper quadrant axis in the ECG. And the lady is Jacqueline Noonan. So this is Noonan syndrome with 1 in 2,000 prevalence, but 70% of them will have a congenital heart disease. And I expect and I invite all my postgraduates to offer your possibilities in the chat box as just now has happened. I was very happy about it. So the most common is dysplastic pulmonary valve followed by hypertrophic cardiomyopathy. This is very important because we people are referred for looking for a cardiac problem in a Noonan syndrome. We said if suppose there is nothing, we don't lose them because they can come up later in adolescence with the hypertrophic cardiomyopathy. So it could come later. This is another 1-month-old baby has mild cyanosis, significant heart failure, and a systolo-diastolic murmur at the base. So baby is really in heart failure, and the serum calcium is 7.4 milligram. And those who are tuned to the MRI pictures, you will find a huge vessel coming from the heart, and there is a smaller vessel coming from the that is pulmonary artery. You are right, it is a DiGeorge syndrome. There are so many names to DiGeorge syndrome, including Catch-22 syndrome. This is, of course, a major novel which came in the 60s. And when we were undergraduate students in 70s, we were very feverish about this particular book. Some of you can still read this Catch-22 by Joseph Heller. Anyway, the point is, in truncus, you have 3 major heart diseases, and 2 are very, very common, more common, tetralogy and truncus arteriosus. So that these 3 conditions, you are mandated to do a FISH to pick up truncus arteriosus. In fact, 15% in Trivandrum, in Ernakulam, Kerala, we have found that 15% of tetralogy will have a DiGeorge syndrome. And then we come to the cardiovascular examination, which includes 2 parts. One is the pulse, blood pressure, and JVP. Then the precordial examination. And it should be in that order. You combine inspection and palpation to avoid overlap and go for percussion and finally auscultation. So basically, I'm planning to give you some scenarios through all these steps. We'll see what would be done. The scene 1 is a boy of 13 reaches the ER with a history of fever, acute chest pain, and is very sick with hypertension. And along with the initial resuscitation measures, he gets an ECG also. So please look at the ECG and then decide what could be the character of the arterial pulse of that boy. So this is the ECG. This is an ECG, a 12-lead ECG. You can see that from 1 to 12-lead ECG. So can anybody guess or anybody think about the abnormality of this particular pulse? Now this is a regular rhythm, but you can see one tall and one short. This is a pulses. No, it is not pulses alternans. It is actually electrical alternates. ECG shows an electrical alternance that is classically found in cardiac tamponade. So, cardiac tamponade presents with the hypotension, elevated JVP, and diminished heart sounds. Claude Beck, a cardiac surgeon, has described this, and this phenomenon is called pulsus paradoxus. That's an article which appeared in 1873 by the transcendental genius Adolphe Kussmaul concerning this particular paradoxic pulse. And we know this can be assessed by blood pressure and by pulse, especially the peripheral pulse. So exaggerated fall of more than 10 millimeter in an adult and more than maybe around 7 millimeter of mercury in systolic BP in inspiration. And this is, I think, the usual question asked: how does tamponade produce a pulsus paradoxus? There is a lot of fluid all around the heart, which restricts the filling. So the ventricular filling is affected, especially in this particular patient. And during inspiration, RV has an advantage over left ventricle, and it is more compliant. So there is a relatively more of RV filling during that period in that kind of famine there. And there is a bulge of the interventricular septum towards the left side, which reduces the end diastolic volume. And then naturally, stroke volume is reduced during inspiration, and it's an exaggerated fall in the systolic BP. So that's a reason for a pulsus paradoxus in tamponade, which could occur not only in cardiovascular issue, respiratory issue, and severe obesity. Now, this is a homework for you. Tamponade, there is tamponade, but there is no pulsus paradoxus, which can occur in two conditions: a severe acute AR and a large ASD with a pericardial effusion. And you must go back and find out why. Ultimately, subspecialty teaching learning is all about why rather than what. So you should know why this is happening. Another scene is a 7-year-old boy with the diagnosis of dilated cardiomyopathy on multiple drugs comes to the OPD with severe dyspnea, sick with hypotension. He has defaulted on his medication for the last 1 week. So what specific character of arterial pulse will we look for a decompensated dilated cardiomyopathy? 3, 4, 5 second pause for a possible chat box answer. Anyway, it is weak, thready pulse, I agreed. But I think more specifically, we are talking about the character of the pulse, which is a pulses alternate. You can get a low volume pulse, but you would get an alternate pulses are weak. Here, it is again regular. This is again regular, weak and strong pulses found in all kind of LV dysfunction due to various reasons. That is the pulsus alternans. And we know possibly there are many reasons why pulsus alternans in LV dysfunction. The most likely reason is that suppose you have a weak contraction by the ventricle, there is a reduction in the stroke volume and increase in end systolic volume, which leads to an increase in end diastolic volume and stimulates the Frank-Starling law and a better contraction next time. But again, it goes back to the poor contraction. That is one mechanism postulated, and maybe a possible recruitment of more fibers after weak contraction has also been thought of as a mechanism. Now, again, in between, I just want to see a link between the art and the arterial pulse, a very famous painting. And there is a very interesting statement by a philosopher from Rome, 50 BC, before Christ era. The physician cannot prescribe medicines. He must feel the pulse. So the importance of pulse has been highlighted, let's say, 2000 years ago. And you must know the definition of pulse that is an arterial pulse, because many times I think I've seen examiners asking the definition of pulse. It's a very difficult, you will be in a very difficult position to answer because it is difficult. Arterial pulse is an abrupt expansion of an artery resulting from the sudden ejection of blood into the aorta, and its transmission throughout the arterial system. And there is another definition. Rhythmic expansion of arterial wall due to the transmission of pressure waves that travels along the arteries due to the forceful ejection of blood during systole into the arterial system. All these definitions, they are very tricky, but some definitions are a must for the examination, including the Frank-Starling law and the definition of pulse. And we also have to draw sometimes in the oral viva to central pulse, which has a percussion wave. There is an anacrotic notch followed by a tidal wave, followed by the rapid descent and interrupted by the dicrotic notch and the dicrotic wave. And, this is very important in terms of radiofemoral delay, because the pulse reaches the radial pulse and the femoral pulse almost simultaneously. That is the scientific basis for looking for a radiofemoral delay rather than brachiofemoral delay. And we know, we have postgraduates, we have know that common causes are coarctation, Takayasu arthritis, abdominal coarcta, very important for pediatric fellows because it can occur in rubella, aortic dissection, spinal cord tumor, embolism, probably more common in adult population. Now we talk about an adolescent of 15 years. He is known to have idiopathic PAH and is on multiple drugs, 2 drugs. And he has come for a review. He is comparatively stable, but has an elevated JVP of 7 centimeter from the sternal angle. So how would you calculate this mean RA pressure? We want to know the filling pressure of the right side. So this is JVP. Again, James McKenzie has iconic article on the study of pulse, all kind of pulses, including venous pulse. And he recorded the venous and arterial pulses, identified and named the JVP waveforms. And the angle of Louis also, is the sternal angle. And Lewis, there is another person called the British Thomas Lewis, who described the methods for detecting the jugular venous. All these people are very important people. And this traditional diagram you see, at any point, the vertical height is to be measured. And this is very important because this is the right internal jugular vein joined by the subclavian vein and goes into innominate and goes into the SVC in a direct fashion. So that is why we would prefer this rather than the left one. So direct continuity has no valves and it's closer to the right atrium. And we have, standard 3 positive waves and 2 descents. And the usual, it's actually the one point I want to say, it is not an indicator of, because during even during my MD postgraduate days, we used to learn JVP as an index of heart failure, but you should not do like it's a window to the right heart filling, both right atrium and right ventricle, especially in the diastole. And you can measure in an older child by asking the child to sit up, vertical height above the medial end of the clavicle, or lying down the standard way with using 2 scales. If you sit up, you need only 1 scale. Anyway, you bring 2 scales to the examination hall and you must assess height of JVP, wave pattern, and the dynamicity, what happens during inspiration and expiration. And the reference point, very important, there should not be any confusion, even if you are assessing the JVP in a sitting posture. And you must measure the height from the sternal angle, not from the root of the clavicle. That is very, very important. And then you can convert it into millimeters of mercury. Adult value, normal value is less than 4 centimeter from the sternal angle. Child is less than 3 centimeter. A is more prominent than V. And in this particular patient, as you will see, more than 7 centimeter with the sternal. You add 5 centimeter for the mid-RA position, extra 5. Many students miss this. You forget about this. You directly convert 7 into millimeter. But if you want to convert this, 12 into 0.75 will give you 9 millimeters of mercury, which is a significant elevation of the central venous pressure or right atrial mean pressure. And these are multiple diagrams, and on your left-hand side, you will find a priest's hood a horse, very unlikely combination, and a British flag. On your right side, you will find the mercury, the original sphygmomanometer, and the Italian flag. So now you see the connection between all these things. It is basically, anybody can offer a chat answer. What are we thinking of? We are thinking of blood pressure. Exactly. So Stephen Hales, who first measured the blood pressure in a horse, and of course Riva Rocci, Italian, first made a mercury sphygmomanometer, and of course Korotkov is also very important because he has assessed the Korotkov sounds. So I will ask another question. A funny looking kid of 12 years has an examination. Right upper limb BP has 110 by 70. Left upper limb is 794 by 68. Lower limb BP is 104 by 70. So the question is, what will be the most likely diagnosis? You remember this value. Right upper limb is 110 and left upper limb is 94, much lower than that. And you know how to record the BP recording and the cuff size, etc. And in this particular patient, there is anisosphygmia, the difference between this thing, correct, Williams syndrome with the supravalvular aortic stenosis, absolutely correct. And pediatrics, of course, three important conditions: pre-subclavian coarctation, supravalvular. But in this patient, the lower limb systolic BP is not very low. So you are not thinking of pre-subclavian coarctation. We are thinking of a supravalvular aortic stenosis. Then fifth, you can have a classical BT shunt producing a asymmetry of the pulse as well as the blood pressure. And a very unusual condition. The child will have both radials will be weak, both femorals will be weak, both carotids are very strong. So you should think of a pre-subclavian coarctation with aberrant right subclavian. There are cases. If there is a case like this, they will definitely keep for an examination. And of course, Takayasu is usually a case for an adult cardiology, but sometimes a child with Takayasu can be kept as a representation. Now, an asymptomatic boy of 13 has an on episode of external syncope, has a basal murmur. There is no cardiomegaly, but there is a sustained apex. So naturally, what could be the diagnostic possibilities? Clinical possibilities in this particular patient. There is no cardiomegaly, but there is a sustained or heaving. Either term can be used. It is basically a significant aortic stenosis. So the apex beat is very, very crucial in cardiology. Where is the heart? Especially in pediatrics, it could be on the right side. Is there a cardiomegaly? Is it an LV apex or an RV apex? Or is there a thrill at the apex? And of course, this is the definition of a normal apical impulse. It's very, very important. It should be assessed in supine position. It is called as a gentle, non-sustained tap. Only one intercostal space, just touches the tip of your finger and occupies only 1/3 of systole. The comment on the area is starred because it is basically applicable to an adult, because in a very small baby, this 2.5 centimeters squared would be a big space. So I would say 1, 2, 3, and 4, 5 would be the definition of a normal apical impulse in pediatric practice. And this is only during the first half of systole, an early outward thrust and a retraction in late systole. And again, location of the normal apex in a child below 2 years is to the left 4th intercostal space in the mid-clavicle line, little horizontal. Above 4 years, it is like an adult. Between 2 and 4 years, it could be either the 4th space or the 5th space. And the types of apex beat could be normal, LV, RV. LV would be oleum, that is hyperkinetic. Pressure, it would be heaving or sustained. So our patient has a pressure overload. So you have other conditions also like HCM, coarctation, and systemic hypertension. And very importantly, LV dysfunction in a DCM or an AS with LV dysfunction, AR with LV dysfunction sometimes can produce a heaving apex. Forceful apex, of course, oleum overload. And the tapping apex, traditionally is due to mitral stenosis, but it can be due to volume overload of the right ventricle. And double apex, you should know, two conditions, one in child and in adult. HOCM could be a double apex. Now, a 6-year-old child is asymptomatic and has a loud basal murmur. Saturation is 98%. He has no cardiomegaly, but has a grade 3 left parasternal heave. So the likely diagnosis would be with a good murmur. Without a good murmur, it would be PAH, but with a good murmur at the base with the LPH, we should think of pulmonary stenosis. So RV activity normally is not felt because of a thin wall and a low pressure, and it pulls away in the early systole compared to an LV, so you don't feel it. But if you feel it, it is basically due to RVH, either to volume overload or a pressure overload. In this particular patient, it was due to a pressure overload. And of course, a subspecialty student will be asked, what is the other cause of left parasternal heave? That is severe mitral regurgitation. And they can ask you the difference between LPH in RVH and in left atrial enlargement. And this is a grading traditionally used by all of us, used to be used. It has been very ancient, but I have never been able to find a regular original reference for this. But it is being used. Grade 1 is just lift your palm. Grade 2 is well felt impulse, can be obliterated. And grade 3 is well felt, cannot be obliterated. I think I found it very difficult for the last 20 years to get a clear-cut reference in print for this. And you should know that the apex PA, P2 would be by fingers, thrill is the base of the fingers, and heave and lift would be the lower part of the palm. The distal part of the palm, proximal part, sorry. Now we have a 3-year-old high volume pulse, collapsing pulse, systolic thrill, left sternal border. I think the diagnosis is very obvious. Saturation is normal, so it has to be a significant patent ductus arteriosus, very clear. And what that brings us to the thrill at the precordium. For example, you have an apical systolic thrill, most often due to MR. It could also be due to an apical ventricular septal defect. The carotid thrill, of course, suprasternal thrill would be due to aortic stenosis. Apical diastolic, we know, undergraduate stuff, mitral stenosis. And this is a question which can be asked. For example, if we have a systolic thrill at the left sternal border, looking at the location, for example, upper sternal border, 3 conditions: pulmonary stenosis, patent ductus arteriosus, and subpulmonic VSD. Mid would be VSD, of course, HOCM and a subaortic stenosis. Lower, naturally, would be a perimembranous VSD. Now, we have another 8-year-old boy with a mild cyanosis, mild desaturation. Come for evaluation. It's a huge heart, and right heart border on percussion is 2.5 centimeter away from the sternal border, which is very unusual because usually it corresponds to the what chamber is definitely enlarged. The chamber enlargement is right atrium, and this is the percussion. Leopold Ornberger wrote a book called Inventum Novum, where he discussed the role of percussion in cardiovascular medicine. And in this particular patient, it is right heart border is due to RA enlargement. Left heart border, you can assess cardiomegaly. If there's a discrepancy between the left heart border and the apical impulse, it could be a pericardial effusion. And in pediatrics, I think it's very important for looking at the situs also, liver dullness and stomach tympany, unlike in adult population. Now we come to what we generally consider as a major part of cardiovascular examination, but it is not. Palpation is almost as important as auscultation. And what is this contraption? This is the first ever stethoscope. This is the making of a stethoscope by Lenne in 1816 and his article in 1819. And this actually is the regular first binaural stethoscope invented by Kaman. Somehow, everybody remembers Lenne and practically nobody knows about Kaman. I think we, as a postgraduate in cardiology, we should remember Kaman also, because I think that he's the person who has made this particular stethoscope, which we still use. And of course, we know we have different kinds of stethoscopes to use for pediatrics. And but the basic point is it should be a good one. It should be a working one. That is very, very important. And one question which they can ask is the inching technique about auscultation, starting from apex, going to the left sternal border, going to the upper sternal border, etc. So this particular inching technique will be asked in the examination. And auscultation means look at the sounds, look at the murmurs, and then make a diagnosis. So start with the heart sounds first, then systolic events, diastolic events, then the murmur, systolic, diastolic, and the continuous. Now, this is a 14-year-old girl with a history of mild dyspnea, fatigue, has desaturation, 88%, has significant cardiomegaly with a well-split S1. Significant cardiomegaly, mild desaturation. What would be the most likely diagnosis? Split S1, not S2. So it is Epstein anomaly. So S1 can be normal or abnormal. Very good. And it can be a loud S1, can be a soft S1, or a split S1 in Epstein or RBB, variable S1. So S1 is actually simple. No, there are only 4 abnormalities. And this is classically a Epstein anomaly. Now you have a 4-day-old newborn, presents with severe cyanosis. Saturation is very low, has a normal S1, single S2, no significant murmur. So you have a newborn 4-day-old baby with the deep cyanosis, hardly any murmur, and a single second sound. Naturally, you should think of a second most common cyanotic heart disease in the world. That would be transposition of great arteries. So what is a normal S2? People will ask you. One is heard at the base and pulmonary artery aortic area. It is a high-pitched sound used by diaphragm, split in inspiration and single in expiration. And don't forget, P2 is softer than A2. So, basically you're all from pediatrics. So we are not taught like this. So you should offer that 5-point thing for a normal S2. So when you say an S2 of this particular child is normal, you mean all these things are fulfilled before committing on a normal S2. This is the normal S2 in inspiration and expiration, very classical normal S2. And we have 5 major abnormalities in S2. Wide split, variable, wide split, fixed, paradoxical split, single S2, and a closed split. And beware, very importantly, in pediatrics, especially in infants, be very careful in committing closed split because the heart rate is so fast that it is practically difficult or impossible to assess a closed split. So let closed split be what you call property of an adult cardiologist rather than a pediatric cardiologist. So single second sound can be either due to the fact that A2 and P2 are close together, like in Eisenmenger VSD. It is because there is only P2, aortic valve is atretic or a critical AS, or there is only A2 because pulmonary atresia or a hypoplastic right heart syndrome there. Or there is only one valve as in truncus arteriosus. Or there are A2 and P2, but P2 is very soft in TOF-like situations or a critical pulmonary stenosis. Then again, both A2 and P2 are there, but P2 is soft because it is posterior. And this particular baby, we had a TGA. This is the reason for a single S2. So there are 6 reasons for single S2 to be present in congenital heart disease. Now we have a 9-year-old boy with a history of COVID in the family. 3 months back presents with a fever, vomiting, and dyspnea, hypotensive. The only auscultatory finding is a prominent LVS3. So naturally, the diagnosis would be a COVID-related myocarditis, which produces an LVS3, which you can see is actually a middle sound. It is not an early sound. S3 is a middle sound. And it is due to a rapid deceleration of blood during all those things are there. It occurs, very importantly, it occurs at the end of the rapid bleeding. So don't say that S3 is an early phenomenon. And you can have physiological S3 in pediatrics, pathological S3, either due to a large flow into the ventricle or normal flow into an abnormal ventricle. So you will get LVS3 in regurgitant lesions and shunt lesions and myocardial dysfunction. Whereas RVS3 in TR, ASD, and RV dysfunction. So you will get this S3. Now you have a A 12-year-old boy diagnosed to have non-obstructive hypertrophic cardiomyopathy, class 2 symptoms. He has only one abnormal cardiac sound, no murmur at all, only one cardiac sound. What is that count? It is basically an S4. S4 is a problem for pediatric trainees because we are not used to S4, whereas adult cardiologists or adult physicians are very much used to it. You should know that this is occurs towards the end of the diastole. It's a very low pitch sound, very palpable sometimes, and it can occur in hypertrophic cardiomyopathy, aortic stenosis, hypertension, and acute MR also can produce this. Manisha, I have a doubt, a problem, because now we have reached 5:20.
Yeah, we can take 10 minutes extra. No issues, sir.
Okay. So I will go up to 5:30 and then we will have 10 minutes of interaction.
Yeah, 5:20 or 5:25, 30.
Okay. Now it's already 5:20.
5:20, 5:90.
Hello?
Sir, this is 5:19.
5:19. So I can go up to 5:30.
5-7 minutes you can take, then 10-15 minutes we can have.
We'll have it. Okay, good. So we have a 10-year-old asymptomatic boy has a grade 4/6 murmur, long murmur at the pulmonary area. We know this is pulmonary stenosis. But what is the cardiac finding which will provide that pulmonary stenosis is valvular? It is definitely an ejection click. So you have both ejection click as well as a non-ejection click. And the ejection click can be pulmonary or aortic, and the pulmonary valvular click is a phasic ejection click, which decreases on inspiration. You must go back as a homework. You should know why does this phasic click occur in PS and why it does not occur in aortic stenosis. Very important. Then an asymptomatic girl of 11 has a funny sounding musical murmur, and before that murmur there is a click, and this murmur increases on standing. So you know you have diagnosed this condition. This is mitral valve prolapse, which produces a non-ejection click, best at apex and medial to the apex. And MR murmur, starts with the non-ejection click. Again, the funny sound of musical murmur is due to MR, which increases on standing. The syndrome is Barlow syndrome. Of course, has many names, as you can see here. He died comparatively recently. And this is a classical MVB murmur, which increases on standing and reduces on squatting and supine position. Another 14-year-old has presented with dyspnea. He has a 4/6 mid-diastolic murmur at the apex. So what additional auscultatory finding? Basically, it's an MBBS question, but just to mention a very important finding in auscultation in severe mitral stenosis would be an opening snap in the beginning of the diastole at the end of the isovolemic relaxation phase, classically in MS, related to the maximal opening excursion of mitral valve, and is mainly contributed by the AML and best at the apex or medial to the apex. And you should, as a MBBS days, we should say whether opening snap is present or absent. But as a postgraduate in subspecialty, you should decide whether it is sharp or dull, and is there too much distance between A2 and opening snap. So if you have a shorter distance, it means it's a severe mitral stenosis. Tumor plop, of course, can occur classically in LA myxoma, and compared to be low opening snap, it is lower pitched. And Twain had said cauliflower is nothing but an educated cabbage. Similarly, pericardial knock is nothing but an early S3. Never commit on pericardial knock in the examination. You say an early S3. And then the examiner will ask you, what is the reason in this particular patient? Then you say it could be due to a constrictive pericarditis. So these are the heart sounds, as you can see. S1, ejection click, non-ejection. S2, opening snap, tumor plop, pericardial knock, S3 and S4. And I think with this question, we will go because there is not enough time to discuss all the murmurs. Have you heard of Reynolds number? Anybody? It's very, very important for the, it is 2000, but you heard about this, right? So this is Osborne Reynolds. He's a physicist. So many physicists have contributed to cardiological examination. And this Reynolds number exceeds 2000, you get a murmur, and it's a function of blood flow velocity, diameter of the orifice, and viscosity. And another practical thing here to just mention is that murmurs, when we were MD students or MBBS students, ancient times, 70s and 80s, Aubrey Leatham has classified murmurs into systolic, diastolic, systolic into ejection, pansystolic. But now we are using the classification by Perloff, more honest classification, where we talk about systolic murmur, 4 types of systolic murmur: early, mid, late, and pan. So you can see 2 are what you call as S1 coincident murmur, which means both have the same causes. And then we have diastolic murmurs, again early diastolic, mid diastolic, late diastolic, and a pan diastolic. Very rare, but once in a while you may get, because it's very important, because you may mistake it for a pan systolic unless you time it very well with the carotids, and you have the continuous murmur. Now I will quickly go through some of the causes of early systolic murmur. Usually it's a small closing VSD, acute MR or acute TR, or a normotensive TR as in Epstein anomaly. Then you can have a pansystolic murmur only in 3 conditions: VSD, MR, and TR. And we have a mid-systolic murmur can be innocent, it can be structural due to so many conditions. Most common cause of a murmur is a mid-systolic murmur. And the late systolic murmur is the murmur which starts somewhere in the middle, usually due to a mitral valve collapse with a mitral regurgitation. And in adults, of course, for papillary muscle dysfunction. And Levine, Levine, this is another standard question they ask, Levine's grading of systolic murmur. And his companion was Freeman, who was probably, people don't remember his name. And then we have the early diastolic murmur, only 2 conditions, AR and PR. And mid diastolic murmur, so many conditions, functional, structural. These are all structural causes of mid diastolic murmur. You know them very well. These are all flow murmurs due to various things. Then we have the pan diastolic murmur. Basically, in an Eisenmenger severe PH, you can have a free PR and you will get a pan diastolic murmur. And the continuous murmur can be in a blue child. Cyanotic classical conditions are pulmonary atresia with a PDA, MAPCA, pulmonary AV fistula, and supracardiac unobstructed TAPVC and truncus arteriosus. And pink child with continuous murmur, of course, is PDA, RSOV, coronary AV fistula, systemic AV fistula, Alcapa, MS with ASD, Lutenbacher with a small ASD. And AP window, basically, only 10% of them will have a continuous murmur. And these are the 10 commandments. When you examine a murmur, you should look at the phase in the cardiac cycle, position in the phase, and grading Levine's length, pitch, quality, maximum intensity, and conduction, and various maneuvers. And lastly, I'm always fascinated by the eponyms like Austin Flint, Gary Coombs, Graham Steele, Hodgkins, Still's murmur, and Gibson's murmur. I think at this point I will stop because it's already somewhat close to the close end.
So thank you, sir. Actually, it is so mesmerizing. It's like just keep on listening and you keep on talking. So it's a beautiful presentation. Everybody is like so much involved.
This is my last sentence. This is also very important. All postgrad subspecialty, all these books have to be read. There is no escape from these books.
Yeah.
And thank you very much.
Vinod.
Vinod.
Sir, thank you very much.
Now it's your territory. Yeah.